Good morning. We're going to talk about a topic related with cancer. It's called reduction in late mortality among 5-year survivors of childhood cancer. The expositor of this topic is Freddy Stefan Versolis, and we're going to define by a childhood study of cancer what is related about cancer. So we can say that the childhood cancer survivor study has assembled the largest cohort to date for assessment of late mortality. 5-year survival rates for most childhood cancers have improved significantly over the past 4 decades. In the modern era of cancer treatment, more than 80% of children diagnosed with a pediatric malignancy will become 5-year survivors of their cancer, due largely to the use of advanced diagnostic modalities and improvements in surgical and radiation therapy techniques, combination chemotherapy, and supportive care. Related to the cause of cancer, we could say that causes of most childhood cancers are really not known. Actually, environmental causes of childhood cancer have been difficult to identify, partly because cancer in children is rare, and partly because it is difficult to determine what children might have been exposed to early in their development. 5% are represented by inherited genetic mutations, and in adults, those genetic mutations are associated with smoking, asbestos, and UV radiation. There's a video to explain the physiopathology of cancer cells.
Transduction resulting in uncontrolled cell proliferation, loss of apoptosis or programmed cell death, tissue invasion and metastasis, permitting spread of the cancer, and angiogenesis, leading to enhanced blood supply of tumors. Normal cells require signals, usually delivered by ligands, to stimulate their growth and to tell them when to stop growing. These signals, or ligands, can be in the form of growth factors and inhibitors, extracellular matrix components, or cell adhesion molecules. These signals are transmitted into the cell through proteins found on the surface of cells called receptors. Each ligand binds to its own specific receptor. Receptors often consist of 3 domains: an extracellular ligand binding domain, a transmembrane domain, and an intracellular domain. When a ligand binds to the receptor, a signal goes to the intracellular domain, activating the associated enzyme and initiating a cascade of signals to the nucleus that tell the cell to grow and divide, or to stop growing. Malignant cells generate many of their own growth signals, which allows them to divide with reduced external growth stimulation. Some cells are able to produce their own growth factors and stimulate their own growth. This is called autocrine stimulation. For example, glioblastomas express platelet-derived growth factor, or PDGF. Sarcomas express tumor growth factor alpha, or TGF-alpha, as well as epidermal growth factor receptor, or EGFR. In normal cells, the production of cell surface receptors is limited by cellular restraints on gene expression and protein translation. In tumor cells, however, mutations in the genes encoding for the receptors disrupts this finely tuned regulation, and too many copies of the gene are produced, a phenomenon called gene amplification. This, in turn, leads to excessive transcription and production of receptors. The end result is a higher than normal number of copies known as overexpression of the receptor on the tumor cell surface.
And there's an expert that talks about the childhood cancer and like its survival, most likely.
We're told that children have the best immune systems because they're fresh, they're newborn. But why are we seeing an increase in cancers in kids that are younger?
What'd your mom do? You know, there's a school of thought that, you know, that it doesn't really matter what the mother does, and there's even headlines now that, you know, that the mom can do this and the mom can do this, and it will not be transferred to the fetus. I don't think that I believe that very much. What the mother does, the baby's inside the mother, and what the mother does will directly affect that child. If she doesn't nurse, it will affect the immune system and the development of that immune system. And above and beyond that, have you seen what our kids eat today? And we're seeing kids with more cancers because the mom drank diet pop. Why do you see young kids with brain cancers now? You think, he hasn't had enough time to develop that. Yeah, he has. While cancer might take 5 years or 10 years or 15 or 20 years in some cases to develop in your body, things can be transferred from mother to child, and other cancers can be very rapidly spreading and grow fast. Our kids drink 1-2 liter pops today. They're getting osteoporosis in their teens because of the phosphoric acid. It's 2.5 pH, so they are acidifying their bodies at a very rapid rate. Some of them are drinking diet pop so they don't get the calories. Diet pop actually helps you put on weight, and it has aspartame in it. Aspartame is NutraSweet. NutraSweet is a very aggressive neurotoxin. It should have never been approved, ever. If you talk to Betty Martini, who sits on our advisory board, she leads the world in the fight against aspartame. She travels the world talking about it. It should never have been approved, and it's killing our children and our adults. And I see it happen just continually. People that become paralyzed, people that are diagnosed with lupus and fibromyalgia and the catch-all MS. When the doctor can't figure it out, must be MS. Crying out loud, folks. Arthritis, diabetes, all these other things we discussed, they're food diseases. We know how to heal them today. All of them. And children have just fallen victim. They've fallen victim to their mother's activities. They've fallen victim to these diets, this lack of transfer factors. All of this plays into it.
So, as the pros and cons of this study, we could say that in advantage or pros, one of them is that the opportunity to gain new knowledge about the long-term effects of cancer and therapy knowledge that can be used to help design treatment protocols and intervention strategies that will increase survival and minimize harmful health effects. And as a second one is that the obligation to educate survivors about the potential impacts of cancer diagnosis and treatment on their health and implementing programs for the prevention and early detection of the late effects. The disadvantage, we refer that childhood cancers make up less than 1% of all cancers diagnosed each year. About a lot of persons in the United States under the age of 15 will be diagnosed with cancer in 2016. Some children inherit DNA changes mutation from a parent that increase the risk of certain types of cancer. Some of the possible late effects of cancer treatment include heart or lung problems due to certain chemotherapy drugs or radiation therapy to the chest area. There's a genetic explanation of cancer.
Hi, I'm Dr. Sandeep Naik. I'm a robotic and laparoscopic oncosurgeon at Max Clinic, Jayanagar, Bangalore. Hereditary. We suspect hereditary cancers when there is a clustering of cancers in a family, that is more than 2 cancers occurring in one single family, or when a young patient comes to us with cancer. In such situations, we generally suggest the patient and the family to go for genetic counseling. And in that counseling, we tend to assess the patient as to what genetic tests need to be done. And we come to based on the investigations and genetic tests, we come to a conclusion whether there is any genetic factor involved or not. There are advantages to this. When a genetic test is done and we detect some, how to treat you. There are times a close follow.
We can say that it's an issue in Ecuador. Actually, the 5-year overall survival rate among adolescents ages 15 to 19 years with cancer exceed 80% in 2007 and 2013, similar to that among younger children, 84% versus 83%. However, for specific diagnosis, survival is lower for 15 to 19 years old than for younger children. Some evidence suggests that adolescents and young adults with acute lymphoblastic leukemia may have better outcomes if they are treated with pediatric treatment regimens than if they receive adult treatment regimens. Improvement in 5-year survival rates for 15 to 19-year-old with acute lymphoblastic leukemia from approximately 50% in the early 90s to 74% in 2017 to 2013 may reflect greater use of these pediatric treatment regimens. Between 1999 and 2014, the cancer death rate dropped most for 1 to 4 years old in a 26%, followed by that for 15 to 19 years old in a 22%, to 10 to 14 years old in a 19%, and 5 to 9 years old in a 14%. We're referring about a study that was realized in Quito about acute lymphoblastic leukemia. And as a conclusion, children treated in more recent decades may have lower risks of late complication or mortality due to modifications in treatment regimens to reduce exposures to radiotherapy and chemotherapy, increased efforts to detect late effects as early as possible, and improvements in medical care for late effects of therapy. Survivors of childhood cancer need follow-up care and enhanced medical surveillance for the rest of their lives because of the risk of complication that can occur many years after they complete treatment for their cancer.